How can we get pharmacists on the care team and make it an expectation rather than the exception?
Patients want to just get better.
There needs to be a revolution.
This is a conversation that we can talk about for weeks.
Ever.
Thank you, Dr. Popovian. Thank you, Dr. Chen, for being here today. As Man School takes on this new adventure, welcome to the first ever podcast by USC Man. So today we welcome our guests, Dr. Popovian, founder of the strategic consulting firm Conquest Advisors, and former VP of Government Relations at Pfizer, and Dr. Steven Chen, Associate Dean for Clinical Affairs at USC Man, founder of the California Right Meds Collaborative, who leads a team of top-notch clinicians who are redefining the impact pharmacists can have on quality patient care. So thank you for joining RxRevolution. Let's begin the conversation.
So I have a very good friend who was a medical director for a very large health system. And he was a physician, actually. And he said, Robert, look, physicians do three things. They do one thing really well and the other two not so well. Physicians are extremely good at diagnostics. They're absolutely the people that should be diagnosing people, without a doubt. But he said the second and the third thing that they do very poorly, and it hurts our health system. And this goes to what Steve was talking about. So he said that one, they prescribe, which they should not be allowed to prescribe, he said, because they don't do a good job enough. They're not up to date with all the information to be able to be good prescribers. Yeah. And the third thing that they do extremely poorly is manage chronic diseases, which we have better healthcare professionals can do that. So having said that, I think that's one of the things that you need to think about, the role of the pharmacist and the prescribing issue that comes in. The second thing I would tell you is that if you step back and think about it, when a physician, and I'm talking about it as an economist, I'm putting my economics hat on. If a physician makes a decision about a patient, that costs the system. Mm-hmm. When a pharmacist makes a decision about a patient, generally that saves them money. Very true. So that's another reason that we need to step back and think about the role of the pharmacist in the overall health system. And that's why a lot of the integrated systems, actually, that Steve mentioned, value pharmacists far more than the disintegrated systems, because they know what the pharmacist can do. And now he can explain what prescribing is.
And the value that the pharmacist has to the healthcare field.
Absolutely.
Yeah. What a great framing. And I think, Robert, you're hinting at places like Kaiser and the VA where they're fully contained, their costs are within their system, and anything they do to improve health outcomes and reduce costs of the system is immediately demonstrated in their results. And every medication has risk and has benefit. Yeah. And I try to explain this to my patients. I can't guarantee you that every medication I give you is only going to benefit you and not hurt you. Right. But I at least have a good idea as to what has the most odds of being of value to you. And I can monitor you very closely to make sure that we manage anything that might cause you discomfort, harm, whatever it might be. One of the biggest problems we have in our healthcare system is really optimization of drug therapy. Right. That means, given a patient with a medical condition, are they on the evidence-based therapies that will delay harm from that chronic condition and potentially prolong their life? Yeah. That's really important.
Absolutely.
I want to add to something that Steve just said. I just thought about it because I've said this for the last 4 years. What cures patients or manages patients is pharmaceuticals. You can talk about surgery too. Surgery has its space, but pharmaceuticals by and large. And if you, again, step back and think about it, how do we diagnose somebody who's hypertensive today? Same way when you and I were students, right?
Yes. I'm sure that's not too long ago.
Yes, but that hasn't changed. Right. But how we manage that patient has significantly changed, and that's because of pharmaceuticals. I have a lot of respect for what physicians do, which is diagnose patients. But at the end of the day, diagnosis is just the start of the journey. The answer, and the true answer, is the pharmaceutical or the surgery if the patient needs it. And I'm going through this with my brother right now, who was diagnosed with esophageal cancer. It was very important to get the diagnosis. But now his hope and dreams and survival depends on drugs, right? it's not about the diagnosis anymore. We know what the diagnosis is. It's all about now the treatment.
Yeah.
And the treatment is what gives patients hope and cure for living longer and happier and healthier.
Yeah, well said. And maybe I can share something that's sort of peripheral, but I think relevant to what Robert just said.
I would love that.
You know, we were fortunate to be part of the late Dr. Ron Victor's Black Barbershop hypertension program back in the mid 2010s. In that program, the concept was pretty simple. Which population of Americans suffer the most from uncontrolled, undetected hypertension? It is the Black male.
It is.
The most, most undetected, undertreated, and as a result, the most strokes and heart attacks, consequently. So there's a situation where we're missing the diagnosis part, Robert, right? We didn't even have the right patients in terms of, identifying them that needed help. So this program was unique in that it was able to identify patients in an environment where they're very comfortable. I didn't know that most Black men cut their hair every 2 weeks, so really good follow-up, right? And it was really an eye-opener, I think, for everybody, because no one believed that you can actually manage a chronic disease in a barbershop. And yet, if you look at the results of that project, what happened? You ended up increasing the number of medications because they needed to be increased. I believe there was something like 1.3 average number of medications in the usual care group versus 2.5 in the treatment group. So there's an escalation in drug therapy to meet the treatment goal of a blood pressure, at least at that time, less than 140/90. It's 130/80 today. And on top of that, you got 90% of the participants to blood pressure goal as opposed to a 33% usual care. That's dramatic improvement in a disease in the number one modifiable risk factor for heart attacks and strokes. So that's an example of what I mean by, we need to do a better job of making sure patients are on the right medications, to Robert's point. I get patients asking me all the time when I work with them. Again, these are patients with uncontrolled diabetes, hypertension, et cetera. They want to get better after they understand more fully what their goals are. But their next question after that is, so when can I get off these medications?
Yes.
Right? And what I try to explain to them is, well, it took you a while to get here, number one. These medicines are critical. I've shown you what they do for you. Could you reduce your numbers of medications? It's possible. The way you do that is through lifestyle modification. But what I emphasize to them is ultimately with some conditions, you really can't get rid of the medications.
Right.
They're really important. Heart failure is a great example where you have to be on those medications even when all the numbers start to look good again. Because once you discontinue, the evidence is clear that you decline and go right back to
And to touch on the heart failure topic, just a personal story, like my dad is a 5-time stroke survivor, and he's had a heart attack. And every time I tell people that story, that's the same reaction I get all the time. And so I've had that same issue with both the de-integrated doctors that he sees, where it's like, you're getting blood work done here, you're getting blood work done here, but the doctors don't talk to each other. And so a lot of times, especially as a first generation, citizen, like with parents that come from another country, the child is mostly the one that is doing the talking with the doctors. And so fortunately, I'm in a field where I understand that kind of scope, where I can direct them to do certain things. But my father, who, he's always like, I have to take these medications. He's a little frustrated with the amount of medications that he has to take. But I'm like, Dad, all of this is for a purpose, right? When you weren't taking your medication, you had a stroke. And so we want you to live a long time. And so medication adherence is what you need to survive. So I definitely understand that point where, adherence is what you need. And like some chronic conditions, especially like heart failure, you can't stop taking the medication. And you just have to rationalize that, like, all right, I want to stay alive. I want to be here. I have to take my medication, and include environmental factors like lifestyle changes, food changes, dietary changes, and things like that. And so it can be a lot for people. So thank you for sharing that information.
Right. But I would also challenge one other thing that improving adherence, which I completely agree, I think is very important. The answer is not autofill.
Yes.
Okay.
Yes.
So that actually devalues
Yes.
the role of the pharmacist, and unfortunately that's the easy answer, right? We put them on autofill and we're just going to give them every 90 days and just automatically
My dad is sick of it. He's
right?
like, I have too many medications.
Right? So that's not the answer, and that's why we need to have human touch be able to manage human beings, and pharmacists are the best people to do that from a drug therapy standpoint.
I agree. But I also think people don't understand the scope of a pharmacist.
Yes.
I think people see pharmacists and they think CVS, Walgreens, Costco, things like that. And up to a point, that was my view of a pharmacist as well. And it wasn't until that I started USC where I'm like, wow, pharmacists are seriously integral to the healthcare system. And so, you know, their wealth, their breadth of knowledge is very important in how doctors diagnose and how pharmacists can treat these patients with the medications, you know?
So I don't know if you saw the data that came out from Bureau of Labor Statistics about pharmacy profession. Drug Channels did a good piece on it. So first of all, it's a 50-50. 50% are in retail. The other 50% are doing something different. You know, just like you and I. You know, we do something different as pharmacists. But the interesting part is that the retail has dropped significantly in the last 10 years. It went from 60% of the professionals being in retail to 50%. So, and it's going decreasing in numbers.
Yeah. But interesting that it remains the face of pharmacy.
That's right. Because it is the visible one, right?
That's right.
People don't see us.
Right.
Well, we do, but they see the person who's standing behind the counter.
That's true.
And that's what we need to change it in that.
Agree.
That unless we can change it and convince these larger companies especially that have a lot of vested interest in this to come along with it, I think it's going to be a struggle.
Well, what is the vision of the School of Pharmacy? To transform the face of pharmacy. So exactly right. I couldn't agree more. I mean, what you just said in the last 5 minutes, I think was really rich. So when I laughed when you mentioned the autofill as being, because I wish I had my slide that I can show you all. But there was a great example of that. There was a patient that was seen in the LA County system.
That's right.
And this patient was seeing about 3 or 4 different specialists, right? And she seemed like a perfectly compliant patient in terms of just following orders from the physicians, and nothing was getting better, right? So finally a pharmacist was called in, and the pharmacist convinced this patient to bring in all her medications. She brings in 100 bottles of medications, about half unopened.
Wow.
And so she's the pharmacist is looking at this set of meds and says, well, you told your physician you were taking your medications. Obviously you weren't. So, you know, what happened? She said, well, I was afraid of side effects, and I didn't want to tell my physicians that I was taking them. So that's one, which is actually pretty common, right? Then the second obvious question is, well, why did you keep refilling your medications? And it's because autofill.
Absolutely.
So autofill checks the boxes on refill dates, which is what we use as a measure of adherence. But to Robert's point.
It's inaccurate because you don't actually know if the patient is taking their medication if you're not actually following up with this patient.
Exactly. And we see plenty of those kinds of issues. So, And along those lines, and something you said earlier, you know, the issue of physicians, how do they perceive pharmacists in this space of doing more than just what they stereotype as being the retail chain drugstore dispensing function? You know, I had just before this meeting, I had a great call with Dr. Kimberly Buss over at UCSF. She's a physician, and she set out, I think in her master's thesis, to figure out, you know, how can we get pharmacists on the care team and make it a expectation rather than the exception. She interviewed 63 people across the nation, from lawyers to pharmacists to physicians. And what you just said is exactly what she identified as a key barrier. She said most primary care physicians have no idea what pharmacists do, right? And yet on the flip side, those that have worked with pharmacists can't get enough of them. Their thought is exactly what Robert said. I want to be able to hand off my patients that I've diagnosed to someone that has the expertise and the focus and the ability to initiate that medication, to monitor, to follow up with my patient, to escalate, to target drug therapies, to get patients to, because I don't have the time, right? To Robert's point, we're not disrespectful of the medical profession. We just acknowledge that they don't have any time.
That's right.
And we're here.
Right.
Use us.
Right.
Yeah.
it's what we train to do, and we do very well. So that's, you know, to your point, I feel like that's the message we have to get across to our physician and other health profession counterparts is, what does a pharmacist really do? What's the scope of what we can do and deliver? So, you know, getting back to my point on Dr. Buss, you know, her goal is to pass legislation to enable pharmacists to be more integrated into systems and be able to provide de-prescribing and other key services, and really PR the medical profession so that they have a better understanding of what it is that we can offer.
Yeah. I agree.
And I would say couple of things, one on the physician side and on one on the pharmacist side that needs to change. First of all, I'm a little cynical. I'm an economist, so I have to say I think a lot of the inability of physicians coming around to utilizing pharmacies because of economics, because they know that they need to have that patient walk through their door to make money. While you go to a system like Kaiser, you don't hear the word scope of practice because nobody cares. Because the physician is as happy to hand over the patient to the pharmacist who's going to do the drug management care, because they know that the patient, first of all, is going to be taken care of, and there's no financial incentive for them to keep the patient, and not share the information. On the pharmacy side, I think one of the struggles that pharmacy needs to come to grips with, and I've had this conversation with National Association of Chain Drugstores, and they agree with me, is that we almost have to get away from making money off of dispensing. They're dispensing, making money off of dispensing, and I know that's how they make money, is what's holding back pharmacy from completely jumping over and doing things that are really value-based. Until that day, until they're making very lucrative money on dispensing, it's going to be hard to pry them back the pharmacy profession on the retail level, and then having to do things like immunizations and things like that.
But then on the flip side, what Robert said is so important. If you talk to pharmacies today, especially the independent community pharmacists, what do they tell you? They tell you, I'm filling medications and losing
money
on each prescription.
Right.
So there needs to be a revolution in what happens in community pharmacies. If they think that they can continue on this path of getting lower reimbursements for prescriptions and still have an operation, it's not realistic. We need to, what we're talking about here, which is leveraging the skills and expertise of pharmacists to provide clinical services like prescribing, that needs to be implemented.
I agree.
Right. And I think what Robert said, he said in passing, but it's really important, is we need to adopt a value-based approach to this. Because if, again, there are disincentives to deprescribing, but if it's value-based, where the patient's outcome is what matters in the reimbursement, then you don't have any conflict.
Yeah, and I think also deprescribing, it has a trickle-down effect. It doesn't, I don't think that it always means that we need to take these patients off the medication, but we can reevaluate the medications that they're taking. And so how is it effective? Is it working? Let's talk to our patients. Let's ask them more questions. I think and a lot of times patients have a level of mistrust with doctors. They don't feel comfortable because they think like the doctors they went to 8 years of medical school. They have all this knowledge. But I'm like, ultimately, you as a patient, you're the one that can say yes or no. You're the one that can switch a doctor if you don't like their opinion, And I don't think people as patients, I don't think they quite understand or grasp that.
I'm really glad you said it that way because, what is it that we're asking pharmacists to do here? What we're really asking them to do is, again, optimize medication therapy. There's a process that's pretty well described now called comprehensive medication management. It's exactly what you just said. You evaluate your patient's medications in the context of their diagnoses. You determine, what is correct or optimal, what is not. And you either escalate therapy or you de-escalate and deprescribe. It depends on that particular patient. And I think that's where, I don't want to oversimplify that concept of deprescribing, right? Maybe I can give you a case example that would help a little bit. I was working with really a very well-known medical leader. And this medical leader asked me to evaluate medications for the spouse. And the medical leader told me the spouse is a Kaiser member. Okay? So I thought, this is a trick question because here you have a really brilliant medical leader. You have Kaiser, an integrated health system where all the data is shared. I thought, I'm not going to find anything, right? So I evaluate this profile. The individual was, I think, in the 70s, so technically would be considered elderly, geriatric. Had about a dozen medical conditions, 24 medications. 4 medications was used to treat side effects that were induced by other medications. There was a doubling of the maximum dose of an antihypertensive that was being prescribed.
Oh my goodness.
There was a side effect of an antihypertensive, and in this case, what it is, it's hyperuricemia, that was causing gout, which was not monitored at all. There's something called serotonin syndrome, which can actually kill you. This patient had every symptom of serotonin syndrome except death.
Wow.
And had 3 medications that were contributing to it. I was floored. I think there's a perfect example of where deprescribing is necessary. And somehow, even in an integrated health system, these things were missed.
At the end of the day, I want to go back to something Steve mentioned, which is payment, which is a very important issue because I'll give you an example. I did a study looking at Medicaid reimbursement for vaccination, right? Which is a no-brainer. You figure that Medicaid should incentivize patients to get vaccinated because they're generally the poor, underserved communities that will benefit most from the vaccine. But 3 out of the 50 states don't reimburse pharmacies for flu vaccination in the Medicaid program.
Oh, wow.
In their Medicaid programs. And it's woefully low what they reimburse, if they do reimburse in some of these states. So again, payment needs to happen, needs to be enough for them to pull away from prescribing or dispensing, making money off of dispensing, so they can do value-based services like immunization. But if we're not allowing them to, or not paying for them to be immunized as Medicaid patients in 3 out of the 50 states, and on the other hand, you're undervaluing and not paying them enough, we're going to be in this vicious cycle of not being able to pry them away from dispensing as the monetary way of making money.
Yeah, I agree. And, even down to the immunizations, a lot of people don't even know that pharmacists can do immunizations. And it's very interesting how often my parents go to the doctor and they don't know that they should be getting their TD every 10 years or that they should be getting their shingles vaccine. And I'm just, what's the disconnect here? What's happening? Why is that occurring? But I also wanted to take a look at an article from the NIH. David, do you mind pulling it up? Number 1. And what this basically states is it says that studies have estimated that at least 1 in 5 and up to 1 in 3 medicines used by older patients are potentially inappropriate. About 2/3 of hospitalized older patients are prescribed 1 or more potentially inappropriate medications. And I'm sure you have more than one story about the cases that you witnessed, but I wanted to get your thoughts on those statistics.
Yeah, well, I think the example I shared with you highlights exactly what
Precisely
that shares, it's a bit frightening how often I would tell you that every review of a senior identifies those sorts of problems. I don't know if you've run across this stat, but I believe 3/4 of all hospital readmissions can be attributed to misuse of medications among seniors.
I didn't.
That's staggering.
Right.
Think about the amount of money that translates into, right? So to our point about value-based here, if you had pharmacists spending more time on deprescribing in those circumstances, think about all the money you would save and all the lives that you'd improve just by avoiding rehospitalization.
That's true. That's true.
And a lot of times it has to do with people don't recognize it's like the patient is getting discharged from the hospital, nurse shows up, the pharmacist shows up, the physician, so whoever shows up at their bedside and says, okay, you got to take A, B, and C. All right, I need to take A, B, and C. When they walk out of the hospital, nobody knows if that A, B, and C is covered through their private insurance.
Nope.
Is it on the formulary? So what ends up happening, they show up at the pharmacy counter. Oh, I need drug A. Well, that's not on the formulary. We need to switch you off of that. Drug B. Oh, well, that one you need to pay full out-of-pocket cost because there's no,
$400.
$400.
Yeah.
So guess what happens? Patient says, thank you very much. Walks
I'm
out
outta
the
here,
door,
yeah.
and it's back in the hospital within a week.
Yes.
And it happens all the time.
That's right.
All the time.
And I wanted to direct this question to the both of you guys. When it comes to the de-integrated systems, what can healthcare professionals do to, make that disconnect essentially disappear? How can we talk more with our patients, talk more with the specialists that they're seeing? What do we need to ask more questions? What do you think?
So all of the above, but I would say from a policy perspective, what we need is even if we're never going to get into a system where everybody is on their Kaiser model, okay, let's assume we're never going to get to that point.
Mm-hmm.
At least what we need to do is make sure that all the patient data is in one place and is held by the patient. I have a producer that I do a podcast with. He's French, so he took it out of his wallet and he has a credit card type of a thing. All his medical information, all his prescribing information is on that credit card. So anywhere he goes within the system of France to get healthcare, it doesn't matter if it's a private physician or a public physician or a hospital or whatever, he gives them that, and that information is all in there. So there's no duplication of diagnosis, no duplication of prescribing. So if we're not going to get away from a disintegrated system where you have pharmacy separate from physicians, from hospitals, all these things, at least what we need to do have is an integrated database that is owned by the patient, not by the system, not by the hospital, not by the physician, not by the pharmaceutical company, but by the patient. and that patient, every time they go somewhere, they can take that information. I think that will relieve a lot of duplication of effort, a lot of mistakes, a lot of overprescribing or underprescribing or overdiagnosing that takes place here. In my opinion, I think if we have an integrated database system that the patient has ownership of, you will probably reduce healthcare costs by about 20 to 30%.
For sure. For sure.
You're dead on, Robert. As you know, we're the only developed country in the nation that is not single payer. So,
and it doesn't have to be single payer.
Agree.
That's the thing.
Agree.
I mean, we
Agree.
don't need a single payer system.
Agree.
We need to have a simple database model.
Yes.
But the patient has to have the ownership of that data, not the system.
Yeah, and I think what's going to lead us to progress in that direction. As some of you may have heard, California has committed to a health information exchange, which is essentially what Robert's talking about. But they said 2025. I'm not going to hold my breath on that.
I wouldn't bet on that.
But at least they've committed to that path, and so I'm hoping in the next 5 years, maybe we get to the point where at least all Californians have a single portal of information for the health info. Yeah. I'm hoping.
And that's the thing. You don't need to change the entire system to be able to get to this point, because in France, like my producer, he goes to a private hospital and he has the same credit card type of information that provides that information on it. So I think if we do that, at least that will be a huge step forward in managing patient care, and it will benefit patients tremendously. And I have to say, a lot of people will raise the question about privacy, right? Mm-hmm. I think it's nonsense. When you talk to patients, an actual real patients, not the advocates that run around in Washington, D.C. and talk about privacy, but when you talk about patients and you say, what if you have all your information? Or what if all your information can be used to help the next patient?
I'm sure they would say yes.
100% of the time. Because patients don't care. Patients want to just get better.
Yeah. And I also think that model, with having them be the ownership of that information, will allow them to advocate for themselves, will give them the confidence to talk to, because they're not only looking over their information, they're asking questions, they're looking at the low values, they're looking at the high values. And so they're going to go to their doctors and say, what's up? What does this mean? How do I fix this? What can we do?
Right. So the biggest barrier, another one besides the privacy people that I think they're out there, but I don't agree with anything they say, is because a lot of people monetize that information.
Yes.
And so that's why you get into these places like you have SureScripts or AllScripts, and you have all these companies that have been for these cottage industries that make a lot of money on transfer of data from patients, except for the patient who owns the data.
I know.
It's their data that doesn't make any of the money, but all these companies. So that's why another hindrance. It's not just the ability. The technology is there and ability to do it there, but there's a lot of people who make money off of transfer of data, and unfortunately, they're the ones that lobby against it.
Yeah. But this is such an important question, right? Because again, in the conversation earlier this morning with Kim Buss, she said that's the biggest barrier. Physicians need confidence that if they're going to partner with a pharmacist in a community pharmacy who's not in that practice and not part of their practice, they need the confidence that that pharmacy is going to have access to information, that there'll be real-time sharing of the actions that are taken, that if the pharmacist makes a therapeutic decision, that they can immediately see it, and if there's a concern, they can actually respond to it. Try to go to one pharmacy. Because ultimately, if you go to multiple pharmacies and you're price shopping, no one's going to have a single record of all your medications, and then the opportunity to optimize meds, deprescribe is lost. But Robert pointed out very eloquently that there are situations where you never have all the medications in one place, such as if you have specialty pharmacy. Exactly. So,
and you're forced into going to some no-name pharmacy, not even in your local neighborhood, not even in your state sometimes, to get this medicine. So it's a problem that we need to address.
Yeah. Let's talk about first of all, thank you for sharing, because I think it's so important, but I also think that this is a conversation that we can talk about for weeks. Yes. Dr. Popovian, I wanted to get your point on like healthcare policies that support or hinder deprescribing methods, and what can we do better about it?
So I would say, one, you don't want the government to be involved in deciding what is appropriate prescribing or not. I'll give you an example. About 25 years ago, the state of New Hampshire, I think, if I'm wrong, excuse me, but they decided in their Medicaid program that the right number of prescriptions was 5. After 5, they weren't going to cover it, right?
Oh, wow.
So if number 6 came and It's a hypertensive
Oh,
drug.
wow.
Too bad. You were out of luck as a patient. But that had significant consequences. So you don't want the government to be involved. What the government can do, though, is do several things. Number one, we've talked about scope of practice. You know, they need to understand that pharmacists are the most healthcare professionals that the patients have access to, especially underserved communities. So if you're, as a government, talking about DEI and you really want to help people who have racial and ethnic minorities, then pharmacy is your
This
answer,
is the way to do it.
right?
Yeah.
So that's number one, it's scope of practice. Number two is better payment mechanism for these things, because without payment, as I discussed, you can't get those patients that really need it. There's no reason why pharmacists should not be paid adequately to provide flu vaccines, of all things, to medicate patients who would probably benefit the most. And then the number three thing I think the government can do is really champion this data transfer issue. You know, I think they need to recognize that a lot of people are making money unnecessarily off of data transfer, and the patient is should be the primary owner of their own data, whether it is prescribing data, diagnosis data, clinical trial data, which is another one that a lot of pharma companies are not very happy about sharing that information with the patients. They should own the data. And if we do those three things, I think you will see a significant change in our healthcare system, and without having to disrupt the entire model.
Yes.
That makes sense.
And maybe to piggyback off what Robert said, Cal Right Meds, our collaborative, is very much speaks to the model that Robert just described. We are working with community pharmacies where these independent pharmacies, by the way, they're not chain pharmacies, they could have practiced anywhere. But they're in these neighborhoods that are the most challenging because they want to give back to their communities. So they are accessible geographically. They have hours of operation that are beyond health systems, nights and weekends. They have staff that speak the language, that are from the same cultural background.
That's important.
I mean, it is. If you can't get past the social needs and challenges that your community has, you're not going to optimize medications.
Not at all.
So,
yeah.
so I think just to leverage those pieces in a value-based model, which is what we do, I think that's the way to sustain it within this current system.
Right. And, you know, we're fortunate. I mean, we have jobs that we can take off during the day and go see a physician if we need to for any kind of services, right? But a lot of times, especially people who live in underserved communities, they work hourly wages.
And that day off, they're not getting paid.
Yes.
So that's why pharmacy is such an important outlet for them to provide the care that they need. So if we don't do that, we're not really serving what we're talking. So we got to, if we're talking the talk, we got to walk the walk.
Correct.
And we're not walking the walk.
Yeah.
Right now.
Agreed. And I think just to, wrap things up, but deprescribing starts the conversation for other things to happen as well. And I think that's important to not only have these conversations, but to talk about these conversations more with different people within our healthcare system, with our patients at home. And so I think it's really important that we keep these conversations going so that we can improve the state of the healthcare system. So, and I think it is important that we have our patients knowing what drugs they're taking, how it's working for them, for what reason they're taking these drugs. And so, I think that's all critical to, the improvement of their health.
Well, can I share some of the basics on how we engage patients? If you think about it, just like the general public thinks that pharmacists are dispensing products out of chain drugstores, they have no idea what we're doing clinically. So when I meet a patient, what I clarify first is that I'm a doctor of pharmacy. I help to make sure medications provide the best benefit for you and the least harm. Would you like to talk about your drug therapy? Just kind of invite them to converse. And what I really get at first and foremost is, do they understand what their diseases are in the first place? What is their diabetes? What is their asthma? What does it mean to them? And I can tell you that no patient comes in understanding what their chronic disease is all about. So I start there to engage them in understanding what happens if you don't control this condition, what could happen. And then on the flip side, I give them hope in terms of, there's a process to controlling them, how the medications fit in. So to your point, once you empower patients with that knowledge about their condition, their medications, how they fit in, and that they can take control of any risk from that medication by learning how to monitor it themselves, it's a different dynamic.
100%,
and it changes outcomes.
Yeah, it'll reform the whole system. Yeah. Dr. Popovian, do you have anything else to share?
No, I think the profession of pharmacy is in good hands. It's moving forward. It's moved forward significantly in the 30 years. I always give this example. When I started at Pfizer in New York headquarters, I was the third pharmacist hired.
Oh yeah, I remember you saying that.
When I left, there were over 600 pharmacists that were affiliated with the New York office. So, in other words, look, the profession is going to move forward. What the students need to think about is that how are they going to be able to contribute to change the profession and help patients. But a couple of things pharmacists need to do. First of all, they need to think about it, that they need to take the word customer out of their vernacular. These are patients.
True.
These are their patients. Pharmacists still in the community, especially in the retail chain drugstores, look at them as customers. They're not customers. They're your patients. The second thing that the pharmacists need to do is become comfortable about talking to patients. And that's another skill set that probably is lacking among all healthcare professionals, but pharmacists need to do that better to be able to move forward. But I think if you start doing those things and some of the other stuff that we've discussed, you can really move the profession. You can make the healthcare system better, and we can save money.
Yes.
Which is the most important thing.
Yeah, my producers are yelling at me. They want me to wrap it up. But I do want to say that I think it is important to change the narrative about how we speak to the patients and how we interpret them, that they are patients as opposed to customers where it's more or less transactional. It's a patient where, it's a conversation. We're trying to change the way that healthcare is right now to make it better for everybody. And that's a wrap for today's episode of RX Revolution. A huge thank you to our incredible guests, Dr. Robert Popovian and Dr. Steven Chen, for sharing their expertise and insights. We hope you found today's discussion enlightening and empowering. Remember, the conversation doesn't end here. Subscribe to USC Man School's RX Revolution podcast for more thought-provoking discussions on the ever-evolving landscape of pharmacy and healthcare. Thanks for tuning in today. Thank you for being here.
Thanks for having us.